Very much for the possibility to share with you our experience with endovascular therapy in the posterior circulation in acute setting. For a very long period of time, we didn't have any proof whether any endovascular therapy in the posterior circulation in acute setting, that means in stroke patient, have any positive benefit for these patients compared to best medical treatment. And here are some very recent quotes from very recent publications that state that the benefit of endovascular treatment in these patients remain uncertain, and title and little is known about the outcome in clinical practice, or if there is some beneficial of endovascular treatment of vertebro-basilar artery occlusion, that remains all unknown. Despite of these publications, we all did endovascular treatment of posterior circulation. The question is why, and probably because we all knew that the benefit is there, and some breakthrough has come in a short time, but it took quite a long time. But recently, at the beginning of this year, they started to present the outcome of a huge and very positive trial. It is a stroke trial in the posterior circulation from Chinese authors in cooperation with American authors, especially Professor Nogueira. This is the attention trial where that points out endovascular treatment in basilar artery occlusion. This is a multi-center randomized control trial, and the aim of the trial was to evaluate the hypothesis of endovascular therapy, that whether it is superior to best medical treatment alone. We have some information about the methods. Patients with basilar artery occlusion were included in time window from 0 till 12 hours with NIHSS over 10 and MRS from 0 to 2. All these patients had no intracranial hemorrhage, PC aspect over 6 and over 8, and they managed to randomize in 1 year 342 patients in China, and randomized them in 2-to-1 manner. 2/3 of the patients went to the endovascular treatment group, and 1/3 of the patients went to best medical treatment group. And then they followed them up in 24 to 72 hours, 5 to 7 days, or discharge, and they followed up MRS at 90 days. So the study endpoints were pretty similar than in the previous studies. So the primary endpoint was favorable outcome, MRS 0 to 3 at 90 days. They had some, of course, serious safety endpoints: mortality at 90 days, symptomatic intracranial hemorrhage at 24 hours, and procedural-related complications. I don't really want to talk about, because these data were publicly discussed in different forums. But what is interesting that according to our knowledge, the rate of intracranial atherosclerotic process in this trial was pretty high, around 40%, what is typical for Asian population. And besides the mechanical thrombectomy techniques, whether it was aspiration or stent retriever alone or combined technique, they also had to perform PTA and stenting in about 40% of the cases. And what they showed that endovascular treatment group had a much better outcome compared to best medical treatment group, and it was statistically very significant. So now we have a very strong gun, and we also know that treating these patients with acute basilar artery occlusion is beneficial for the patients to treat them endovascularly. What is additionally positive in this study, that they managed to prove that treating these patients endovascularly saves lives because they had much lower death rate compared to best medical treatment, and it was statistically significant as well. So this is my country, where I come from. It's Slovakia, in the middle of Europe. And our stroke center is the biggest stroke center of the eastern part of the country. It is a region with 1.5 million people. And we perform about 260 mechanical thrombectomies per year, and also we perform some acute stentings or PTAs of supraortic vessels in acute manner in number around 60 per year. This is our angio suite. And I would like to start to share with you our experience with one case report. It was a 67-year-old lady with a history of hypertension that she suffered sudden loss of consciousness with vomiting at 12:48. She was immediately admitted to the primary stroke center. That is a city like 40 kilometers far away from our stroke center. She was admitted with NIHSS 10 points. They performed immediately native CT and CTA without new ischemic changes, but with the finding of basilar artery occlusion. So they immediately she was administered thrombolysis and transported to our thrombectomy center, and we started our procedures 1.5 hour later than her difficulty started at 3:06. So this is, I don't know if, yes. So this is the baseline MGO. There we see a stenosis at the tip of the vertebral artery, and we see occlusion of the basilar. So what we have done, we did a pre-dilatation. We went through with a wire, of course, a control angio from the microcatheter, and we did a pre-dilatation of the stenosis. And this is a control angio, so we see occlusion of the tip of the basilar. We did one passage of thrombectomy. This was the result. We had some distal embolization to the posterior cerebral artery, so we did another thrombectomy, and it looked quite well. But after several minutes, we had reocclusion, so we decided to deploy a stent immediately to the V4 segment. And here we have a short video. We sometimes use microcatheter to deploy the stent, and we just put a stent there through the SL10 or any kind of microcatheter with 0.17. And on the next video, we see that, and I would like to point out it maybe for the industry, that sometimes we have difficulties to pass through the one of those markers of the stents, and we don't really know what is the reason. So you just have to gently play with the pusher wire and pull it out and push it back and try to manage to get through with a microcatheter. But finally, usually we always manage, and it's not something that we cannot get through. After then, this is the control angio, pretty good, but we always, when we suppose that we have an ICAD, we always do post-dilatation, and here is the angio when we are getting the balloon into the CREDO stent, and you see there was a contact of the stent with probably a balloon with the strut of the stent, and it can push the stent a little bit forward, so you have to release the pressure and the tension a little bit, and then you manage to get through. Here we use, if we don't use the Neurospeed balloon, we use a lower profile balloon, just because of the getting through of the stent, and also it is easier to inject through the 5 French Sophia, the contrast. So we are using mostly the Neurospeed, but not all the time. And now we have the control NGO. So it was pretty satisfactory result. The procedure took 1 hour, and then we finished with this result. Next day, of course, the patient went to dual antiaggregation. We are using IV cangrelol with IV aspirin in acute manner or in acute setting. but this is the control CT. Next day there is a hemorrhage in the mesencephalic area. But the patient was stable, so we waited. We reduced the anti-aggregation to only aspirin, and we did a control CT after 72 hours, and the hemorrhage was not growing, so we left it like that. Then the patient was doing well, clinically improved from NIHSS 10 to 5, and she was transported to local hospital 5 days later. We have a 90 days follow-up. She was MRS3. So finally we got to the era where we have very strong clinical trials for anterior circulation and also for posterior circulation. So we probably know how to treat these patients, but we also think that we should do a very close follow-up for our patients to find out whether we are treating them well. Nevertheless, we can have some mistakes in our management. So we also follow up our patients, and we did a very close follow-up from May 2021 with an approval of our ethic committee from the hospital, and we collect all data we are able to collect, demographic data, risk factors, NIHSS, pre-stroke MRS, procedural details, and we follow them up at discharge 30 days and also at 90 days. Okay. So we have from May 2021 till April 2022, in 11 months, we had 66 patients with posterior circulation stroke that we performed endovascular therapy. It is like 20% of all stroke patients that we are treating, approximately. And from this group of patients, we had 38 patients that had occlusion of the vertebrobasilar region. Then we had other 10 patients that had no occlusion, but they had symptomatology, recurrent symptomatology of hypoperfusion of the posterior circulation. So we treated them endovascularly in acute manner. And we had other 18 patients. They had also symptomatology, but they had extracranial stenosis, like bilateral vertebral artery stenosis at the origin, and so on. So what we found that we also have pretty high rate of intracranial atherosclerosis, severe intracranial atherosclerosis in our patients. We have almost 30% of the patients with severe ICAD at the posterior circulation. So this is a situation that we cannot avoid, and we have to be prepared for that. So we divided our patients to two groups. First group had occlusion of the vertebrobasilar region somewhere, and we performed mechanical thrombectomy. And the other group that had no occlusion but had recurrent symptomatology. So when we evaluated the first group with occlusion, we were able to follow up 85% of our patients. But we have some data from all of them, and the initial NIHSS in patients with occlusion was 10. At discharge, we had 2.3 NIHSS. We managed to perform or reach TICI 2B or 3 in 100% of patients. We had TICI 3 at almost 81% of patients. So MRS score 0 to 3 at 90 days from the followed up patients, we had 78.8%. And we had 13.15% death rate in these patients that had acute occlusion and who had a reperfusion. We had also some asymptomatic intracranial hemorrhage at 24-72 hours in rate of 8%, and symptomatic intracranial hemorrhage in one patient. Then we looked closer to patients with only stenosis in the vertebrobasilar region intracranially. These are low numbers, so it can change in time, but we can have an imagination how it works. The baseline NIHSS of these patients was lower than compared to the patients that had occlusions, and the discharge NIHSS was 3.3. That is not that had a nice improvement as we've seen in the occluded group. And we had MRS-03 at 90 days at 7 patients. Three patients died in a 3-month follow-up, and we had 1 symptomatic intracranial hemorrhage. So if we compare, but I would like to point out that these are real life data, and if we compare compare studies from anterior circulation and the very promising studies from posterior circulation and compare it to real life data, we see that there is a difference, because we have much higher mortality in 3 months in the anterior circulation from real life as we've seen in the studies, but the real life data are very similar to the trial data at the posterior circulation. So I think that mechanical thrombectomy has even higher impact in posterior circulation than in the anterior circulation, and especially as the attention trial investigation showed, we can save lives with endovascular treatment in the posterior circulation. So in conclusion, let me say that results or upcoming results of attention trial clearly demonstrate benefit and efficacy of endovascular treatment in posterior circulation stroke. EVT in these patients is associated with favorable overall clinical outcome, higher rates of functional independence, and lower mortality rate. Since the contribution of ICAD in the etiology of posterior circulation strokes is significant, stroke centers should be ready to solve these problems, and they should be ready to solve also hemodynamically significant dissections, not only ICAD, but dissections are not that frequent, but we can come to contact with them as well. And finally, I would like to say that endovascular therapy offers overwhelming benefit in treatment of stroke with LVO in anterior circulation as well as in the posterior circulation. Thank you very much.
Thank you very much. Very interesting data, and I believe this is something we really need, because as you pointed out, we gain more and more data for the anterior circulation, and like ICAD in the posterior circulation is crucial. How about technical success? You didn't mention it, but I believe the technical success, like when you intended to do PTA and stenting, was very high.
Yes.
In your data, so like 100%.
Well, like 100%, yeah. Yeah, we basically technically it's not that huge challenge. It is possible. So of course, sometimes you have difficultier cases, but more difficult cases. But as everybody's mentioned, we are always a little bit afraid of hemorrhage. We are not really sure whether the antiplatelet therapy is appropriate, or we are not, because some of these patients receive thrombolysis. We give them also heparin, we give them aspirin, we give them some GPI. So sometimes you might have a feeling that it is a little bit too much, but you want to keep the vessel open as hard as you can. So
I believe we have one online concluding question, actually. Walter is asking, what dose of IV cangrelor and aspirin are you using in your patients in the posterior circulation?
What else? We are loading them with 100 milligram of aspirin, and we are using 1/3 or 1/4 of the recommended dosage of the cangrelor. As we discussed with a colleague yesterday, we are able to manage the inhibition of aggregation, and the Verify test showed us that if you give the full dose of the cangrelor, you reach 100% of inhibition. And maybe it's too much, especially in acute setting in stroke patients. So we usually reduce the dosage, and and we are satisfied if we reach 1/3 or like 30% of the inhibition, since we are since this is a stent. So when we are implanting flow diverters, we are satisfied if we reach over 50%. So we don't need that much inhibition, and I don't remember a case if we had an occlusion of the stent. So this is not really a problem.
Okay.
Technical question. So you showed us you implant the stent and you make a post PTA through the stent.
Yes.
In my experience and in experience of other colleagues I work together with, it's quite likely to damage the stent or to push it or that it jumps. So do you really like to make a post-stent PTA?
Well, is the question whether it would be better not to post-dilate at all?
I think so. I've seen a lot of problems occurring when you post-dilate and when you dilate, pre-dilate, and then just drop the stent
it's like not 100% of the cases, but we are much more satisfied if we post-dilate than ICAD.
Okay.
We are not post-dilating flow diverters, for example, for no reason in my point of view, or if you feel that you made a pretty good pre-dilatation and then the control NG after stenting is very good, then of course you may not to post-dilate. But since it is an ICAD, you may expect that after a time. We are doing 3-month follow-up, but after a year or 2 or 5 years, there can be a restenosis as well. That might be or should not, or might not be a problem, but we are not trying to reach the maximum of the diameter, some submaximal diameters, but we try to post-dilate. Of course, you have to be gentle and curious about that, but I think it's not that huge problem. If you have a big magnification and focused on the contact of the balloon with the stent, it can be manageable, I think.
So, one last question.
So, I don't think we recommend to post-dilate, correct? No, we don't do it. And so this is a self-expanding stent, and the CREDO has quite a nice high radial force, so we think the stent should do the rest, so it applies a constant radial force, and that should be done. So I'm not a clinician, so I can't give you an advice to post-dilate or not, but we don't recommend it.
I have a general question maybe to you and maybe to the others. If you do acute intracranial stenting, when do you do your control? Do you do control angiogram, and when do you do it? Do you do it earlier than in elective cases?
If may I answer, we don't do regularly control angio, no. Not even control CT angio, basically.
Okay. You do
if
ultrasound?
If the patient is symptomatic, of course, then all this machinery starts to work, but basically no. Well, I think it can be a long time problem after several years. For example, as a colleague showed from Italy, that he put a long stent in a young lady basilar artery. She was like 39 or something, and we don't know what will be in 30 years. It can be a problem, or in 20 years, and she will be still just 50 or 60 years old. So we will see. It's again a question whether how long can we treat these patients with dual entry aggregation, whether it is beneficial for them to have them for a long time on dual or not. We just don't know. We don't have data for that.